Okay, now we will continue with the next common problems that we encounter in inpatient. So for UTI, it's common. Patient came in with a frequency, urgency, dysuria. You do full physical exam, and then you have to do your differentials in your mind. And the orders is you do them based on differentials. So obviously CBC, BMP, you do that. You can do beta HCG if a female is pregnant. So this is very important. If the patient there is some search criteria, you can do blood culture. UA with urine culture is very important, and usually it's ordered by the ER. And then you can do renal ultrasound if you suspect pyelonephritis, and CT abdomen if no improvement in 72 hours. And the treatment, usually you treat with Rocephin. This is the common medication: Rocephin, Cipro, and Bactrim. And if you think the patient is pretty sick, you can add you can do Zosyn. Okay, that's also used. And the usually risk factors for for people who are immunocompromised, recent hospitalizations, we can add those. We can do stronger medications. And the risk factors for UTI include diabetic, if they have urine incontinence, if they are pregnant. So these kind of increase. And then the plan, usually once they're able to tolerate oral fluid and oral medications, then you can send them with antibiotics for 10 days or so, 5 to 10 days, and then follow urine culture. This is very important. And then narrow, you can, if they're sick, you can wait for the culture results back, and then you narrow down the antibiotics and send them home on that. And if the culture negative, then and they're just send them based on the sensitivities of the culture. And if they are doing fine, you can just send them and then follow up with the PCP, so follow the culture with the PCP. The other thing I noticed that a lot of people do UA, urinalysis, they do esterase, and they're not symptomatic. So this is not an actual UTI. So just gotta be mindful of that. You don't need to use antibiotics. If the patient just have esterase, you're not treating esterase. You're treating symptoms. They have frequency, urgency, dysuria. So symptoms matter a lot. It's more important than just cultures or UA. And some cultures are contaminated. So this is one thing to keep in mind for UTI. So another very common presentation that we encounter is that heart failure. Heart failure is very common, unfortunately. And heart failure symptoms, usually if there is left heart failure, they usually have dyspnea, crackles, curly beeline on x-ray, and some effusion. So it's pulmonary symptoms. If it's right, you have systemic symptoms, because right heart gets from the system, gets supply of blood from the system. So if it's not pumping, it's going to back up to the system. So you have leg swelling, abdominal swelling, weight gain, early satiety, these kind of things. And usually someone who have heart failure, they have other comorbidities: hypertension, hyperlipidemia, they're a smoker, they're not compliant with their medications, these kind of things. So the first thing, you examine them, you make sure they're breathing right, look at their extremities, are they cool, JVD distension, crackles, there's any hepatomegaly. And there's a different classification. Usually the common one is NIHA classifications. Class 1, they have no limitation. Class 2, they have limitations with exertion. Class 3 with ADL, and Class 4 at rest. Common orders that we usually do for heart failure is that we check obviously CBC. You can do CMP, is very important, cardiac enzyme, troponin, TSH, urinalysis, BNP. This is important. If it's more than 300, 500, indicate possibility of heart failure. ABG, if they are in respiratory distress, needing oxygen, lipids panel, A1C, these kind of things that you want to look for. And the differential diagnosis for heart failure is COPD, could be pulmonary embolism, pneumonia, cirrhosis. So now we come usually for the common treatment that we usually do. So there's a lot of trials that showed that there's a mortality benefit for somebody with heart failure. So if it's HFrEF, usually we add metoprolol. If it's tartrate, twice daily. This is T with the T, so you gotta remember. If it's succinate, it's sustenate. It's one time daily. So that's the difference between metoprolol. And metoprolol, based on the MERIT trial in 1999, it showed that actually decreased mortality. So that's why you see everybody on metoprolol. The other thing that you will see is that lisinopril or Entresto also showed mortality benefit. The paradigm trial in 2014 that was showed Entresto is beneficial, and lisinopril, it's been proved a long time ago. I think it was the SALT trial or something. And then you can, if they have heart failure below the ejection fraction less than 35, you can, some people, you see them on spironolactone. And if they have also obviously cardiologists on board, and sometimes they give them ICD because it also showed a mortality benefit if someone have EF less than 35 and QRS more than 150. Duration more than 150. So this is the things that you want to look for. These are very important. And then for African American, they showed the hydralazine, dinitrate or MDUR or mononitrate, showed beneficial as well, has some mortality benefit as well. It's called the AHF trial, okay, or something. So, and usually given for patients who have renal failure, they cannot tolerate lisinopril. And usually once their blood pressure tolerate, that's when they start these medications. And the other comorbidities, if they have obstructive sleep apnea, you give them a CPAP. If they have anemia, you give them iron if they're anemic. And then SSRI, if they're depressed, you give them statin. If they're hyperlipidemic, you manage their diabetes. And on discharge, you emphasize med compliance. You can order the heart failure education, med compliance, low sodium diet, so that they don't overload. A lot of patients, heart failure exacerbation, heart failure patients, they tend to be volume overloaded quickly. So a lot of patients, you send them, give them some Lasix. So this is the most important thing actually in acute setting, Lasix. We give them Lasix just to get the fluid off of them, and usually they eat something salty, and they get fluid overloaded, and they come back again. So it's very common reason for readmission. So this is the heart failure issues. So for COPD exacerbation, usually someone who have a productive cough more than 3 months in a year for more than 2 years, this is a kind of a definition of a COPD exacerbation. And usually you ask them about fever, chills, nausea, vomiting, just to exclude pneumonia. You ask them about chest pain, exclude heart failure. You ask them about their medical history, if they have COPD, heart failure, asthma, cystic fibrosis, diabetic, a medication that they're taking, are they compliant with their inhalers, how much home oxygen are they on, if they're on any home oxygen, they have obstructive sleep apnea, are they on CPAP. So these kind of things, and then you examine them, you do follow exams, general appearance, are they breathing in distress, how much oxygen are they on when you see them. And you do labs based on the differentials that you think of. You think is it pneumonia, is it CHF, is it asthma, is it bronchiectasis, is it pneumothorax. So the way you do it, you do CBC, BMP, and then you can do D-dimer if you suspect PE, and then cardiac enzymes as well, troponin, ABG if they're in respiratory distress, sputum culture, X-ray. Sometimes you do CTA if you suspect PE. And this is the common one. And then anybody with COPD that comes to the hospital, you want them on Doaneb, Brio, and increase. And you just watch out, you know, the duonep has ipratropium, so you can just add albuterol, brio, and increase. Duonep has ipratropium. Increase is LAMA. It's a long-acting muscarinic antagonist, so it could cause some urine retention. Just watch out for that as well. And sometimes you even add antibiotics, and the antibiotic usually azithromycin, Z-Pak. Azithromycin. Sometimes Recefen, you see that commonly. You see Zosyn if the patient is more acutely ill and you're suspecting Pseudomonas or suspecting something serious. And then you give them prednisone, methylprednisone, every 6 hours, and usually 125 milligram. Okay, or you can just do prednisone 40 q day for 5 days, and you don't need taper for this one. Okay, this is based on the reduced trial, showed that prednisone reduced the hospitalization days for COPD exacerbation. And once they get better, if you have a hard time weaning them from oxygen, you can do home oxygen evaluation. And if they are very sick, you can consider pulmonary consult as well, especially if they are less than 40 years old and they have more than 2 episodes per year, recurrent exacerbations. It's a good idea to have a pulmonary look after them, and they may need outpatient pulmonary function test. The pulmonary is going to do that, and you educate them about smoking cessation. I know it's hard, you know, but smoking cessation it's a good thing, you know. Makes you a great doctor if you just kind of talk to them about it. So this is kind of a summary of the COPD exacerbation. Maybe let's talk about one more thing. Pneumonia, usually, in addition to the history, usually there is common orders that usually specific for pneumonia. MRSA screen, I see that commonly ordered. I learned that from the pulmonologist. Legionella, strep pneumo antigen, sputum culture. If they're very sick, you can do blood culture. And you can do CBC, BMP, urinalysis if you suspect with urine culture. If you suspect some sort of UTI, and then you can do chest CT if you think it's a post-obstructive pneumonia, or X-ray showed some sort of obstruction. You can do CT chest if they're acutely ill. It's just like a UTI. If they're no improvement, you can do just abdominal CT. This is the same thing as well. You can do that. Because it could be cancer, okay? And the reason for these tests, we're looking for the differentials, which could be PE, could be COPD exacerbation, could be cancer, could be bronchitis, empyema, could be histoplasmosis, blastomyces, heart failure. These are the things that we look for. That's why even we do full physical exam, we assess everything, and then we ask them about if they have HIV, if they have any neurological disorder that causes them to aspirate, if there's any nausea, vomiting, recent illness, sick contact, shortness of breath, fever, chills. And we can use even the CURP 65. We'll talk about them later. And usually for antibiotics that I see them commonly, if they no hospital acquire, if it's acquired from community, they haven't been admitted recently, then this is community acquired pneumonia. Usually the medication that I see commonly used are Recefen and azithromycin. But if it is a hospital acquired pneumonia, like they've been in the hospital recently, I see Zosyn commonly used, because Zosyn could cover anaerobes and could cover Pseudomonas. I also see Levaquin commonly used, And you can use the CURB 65 to decide the admission. CURB 65 basically C for confusion, U for BUN, give them 1 point, R for respiratory rate, it's 1 point for that. If it's more than 30, B for blood pressure, if it's less than 90 over 60, if it's low, this is give them 1. Age more than 65, you give them 1 point, and usually if it's 0 or 1 point, then they have 1% mortality. This is outpatient care. If they have more than 2 points, then this is 9% mortality. You need inpatient versus observation. And if they have more than 3 of these, then this is 20% mortality. So you gotta do inpatient admission and even consider ICU admission with a score 4 or 5, and pulmonary involved as well if they're bad. So your job is to assess how bad is their medical situation and decide if you need to involve the consultant or you can manage on your own, or these kind of things. And before discharge, usually make sure they tolerate PO diet and PO pills as well. Usually we send them home on Cefdinier, or if they have blood culture positive, you do Levaquin for 2 weeks or 10 days. Send them on oral medications, and you can evaluate for home oxygen use as well if they require a hard time getting off of oxygen. And make sure you mention the note to get vaccinated at the PCP office for pneumonia, influenza, and these kind of things. Actually, I've seen really bad influenza, so sometimes people who don't take influenza vaccine, this is a bad, could be really bad, and they will be on vapotherm. And every day you assess their oxygenation status, like if they are on vapotherm, if they're needing BiPAP, they're needing ventimask, so vapotherm. And then if they can go down to ventimask, then this is better. If they go back down to nasal cannula, it's even better. And then the goal is to have them on room air if they can tolerate. So this is kind of a summary of these things. I don't want to make the video too long. So UTI, usually UA, blood culture, Recefin or Zosyn, and the heart failure, usually you can do echo as well, ABG, Lasix. If they haven't had an echo in a long time, you can do that. Lasix and Entresto. Lasix usually would get the volume overload out, and then COPD exacerbation, usually methylprednisone, Breo, Incruz, albuterol inhaler, and you can add antibiotics as well. And pneumonia, usually MRSA screen, Legionella, sputum culture, blood culture. Recefin, azithromycin if it's CAP. If it's HCAP, you can do Zosyn, you can go abroad, and CURB 65, and then you can send them home. And both in COPD exacerbation and pneumonia involve the consultant, the pulmonary, if they're bad, so that if they look bad, so that they can even follow them as an outpatient as well. So this is a kind of a summary of these these a few medical problems. So I'll let me know if you guys like that, so that I can make more summaries of the more common things that we encounter. Thank you for listening.